Hey, N313, this is your instructor Sam, and today we're going to be going over our first performance test for the week, or for the course, which is inserting a peripheral IV into a patient's arm, and then also hanging up a secondary bag of IV fluids, whether that's an antibiotic or other piggyback, on top of a primary bag.
Before starting the procedure, it's important that you review the entirety of the chart. This includes Martha's medical history, where we learn about a respiratory infection, the physician's orders, giving us insight on what cares to perform, and the medication list, which reviews that Martha needs IV antibiotics. Knowing this, we will decide what pertinent assessments and interventions to perform. Unlike previous performance tests, we're going to gather some of our supplies beforehand, as we know we're going to need to place an IV. When you enter the room, be sure to wash your hands and introduce yourself. Be sure to incorporate welcoming gestures, such as eye contact and friendly touch. Elevate the bed to a height that is mechanically comfortable for you, and while doing so, feel free to ask Martha her name, date of birth, and allergies on her wristbands. This is essential to ensure you have the correct patient. Be sure to then perform a targeted assessment and explain to Martha about the interventions you plan to take. Discuss what she can expect and how long it will take. Ask her about where she would prefer to have an IV. You can then take this time to educate Martha on the medications you'll be running through the IV. When you're both satisfied, feel free to start the procedure.
Before we actually put in the IV, it's important that we gather the correct supplies. We're going to be gathering the supplies for the IV insertion before we go into the patient's room. And when we go in there to do our assessments, we'll be explaining what we're going to do, and then we'll just have the stuff right there for us. In terms of the secondary medications and everything, we're assuming that some time has passed because the primary set will already be initiated for you on the IV pump, and we'll just hang that bag then. So let's get to it then. So with IV insertions, we need a couple different pieces of supplies. First and foremost, we do need the catheter that we're going to be putting into the person's arm, and these are covered with a needle stylet. I will open one up here just so that you can see what I'm doing. Ideally, you would not open this in the supply room. You would wait until you're in the patient's room. But these angiocatheters, is what we call them, angiocaths, are designed so that you can use a needle to guide a rubber catheter into a vein and then advance the catheter without advancing the stylet or the needle, and then extract the needle safely when you are ready to be done with the insertion process. So the stylet helps guide the catheter into the vein and has a sharp end on it to do so. We're going to show you just some of the basic components here. If you look at this, there is a button that's white here. It's important that you take note of where that is so you don't accidentally hit it before you actually intend to use it. That's going to retract the needle into the base of the angiocatheter handle, and if you extract it early, you can't pull it back out. So if you don't have the catheter in yet and you accidentally hit the button, you can't use the catheter anymore and you have to use a new one. So I'm going to take the cap off, and it's going to be kind of hard to see here exactly, but you're going to have two components. You have the catheter, which has got a hub here, this light blue part, and then inside of it there is a needle that's on the inside. And what you're going to be doing when you're inserting the IV is you're going to advance the whole thing in, and then at some point you're going to feed the catheter, just the catheter, not the needle, into the rest of the vein, and then you're going to retract the needle. Now I'm going to take this off so you can see the actual needle inside, and then I'm going to hit the safety retraction button so you can see just how that effectively stored itself in here so that you can't poke yourself when you're done. So those are the components of the angiocatheter. I'm going to throw this in a sharps container really quick because I don't want there to be any poking even during the demonstration. So ideally I would want one or two of these angiocatheters just because there's a chance you might not get it on your first poke, and you want to be prepared to be able to go again without too much trouble. But for the sake, I just used my secondary right now to show you that. So assume you have two of these. It's a good start. You're going to want your IV starting kit. I'm going to open one up here just so you can see what's inside. We have a couple different components here. There's a, let's see here, let's get it all out and then I'll show you what's going on. These are the sort of the supplementary things that you use surrounding that needle, but it's not going to be everything, and I'll go through that in a second. But inside the kit, you're going to find that you have a betadine swab. And in real life, to perform the skin care on the arm before you insert the needle, you would want to use something a little more potent than alcohol. You're going to see people use alcohol in practice. It's not best practice to do that. That being said, our mannequins cannot really use these iodine scrubs. If you use them on the skin, it doesn't come off very well and it's really sticky. And the other option would be chlorhexidine, which you can use on the arms, but we don't have a lot of those wipes here, and they're very expensive. So what we're going to do is we're going to pretend that an alcohol wipe that you have for this part of the procedure is a chlorhexidine scrub, and you're going to have to verbalize that it's chlorhexidine and not alcohol. So we have our skin cleansing here. We have a 2x2 gauze. This is helpful for two reasons. One, if you miss the poke and then when you extract the needle, they're just bleeding, you might want this to help cover it up. And two, when you are inserting the IV, even if you do it correctly, and especially if you do it correctly, you could still make some sort of a mess. And if you're making some sort of a mess, it's nice to be able to use these 2x2s to wipe up the blood spill and prevent the patient from just having blood all over their arm when you're trying to put the dressing on. There's also a tourniquet in this kit, which I have an unrolled one here. I just want to keep it rolled up for the sake of demonstration. But the tourniquet is going to be used to stop venous return blood flow in the arm from wherever we set it. So if we place it on the upper arm, we'll still have arterial flow, bringing blood from the heart to the fingers and distal extremities, but on the way back, it'll sort of get into a traffic jam wherever we have this tourniquet set, which will help the veins expand and become very full of blood, which is good because if they're bigger and more stretched out, they'll be easier for us to poke and gain access into. So we're going to want this definitely for the procedure. It comes with tape. You can also bring a second roll of tape that's a little thinner. This might be a little more useful if you plan to use tape to secure your hub once it's in, but you haven't gotten the dressing on. And the thinner tape is also, it could just be a little more useful in general. But we use this kind of stuff all the time in the workplace, like this size, and that's fine. You can always also pull it and then split it in half as well. So we got some tape. We have a tegaderm dressing. This is very important because we want one of these dressings that promotes oxygen perfusion through the dressing. That's one of the advantages of it. But it's also going to stop water from getting onto our IV site. If they get really wet, they tend to fall out and not be as effective. So this is going to protect us, kind of waterproof us. And it's also going to be clear so that we can continuously observe the site and make sure that nothing bad is happening to it. On this dressing as well, there's a cool little spot here where you can put your initials, date, and time information on here. You can also just write that on a piece of tape. It does not matter to me as long as you are indeed identifying who did the IV and what time it happened. That's fine by me. We used to have you draw up your saline through a vial, but in the real world, you're going to be getting these pre-filled saline syringes that are sterile by nature. So if you take this off and you touch it, you'll contaminate it. But as it stands right now, if you take this and you pull it off, you're good. These are not meant to be reused regularly because we don't really know what's been going on with the barrel here. But we have a little extra space in here. They're not quite usually full at 10 cc. Some of them are, that's fine. And we'll be using this to, one, check to make sure that we get blood return when we hook up the IV, and two, that when we flush it afterwards, that we're actually flushing saline, which is a non-irritating, non-vesicant material or solution. We're going to make sure that it's actually going into the vein and not the surrounding tissues, because if we tested it out with something like potassium or vancomycin, we could cause massive skin breakdown and irritation if we aren't still actually in the vein. We'll get more on that later. We're also going to be using, we're going to call it, some people call them J tubes. This is just an extension tubing set. Yours is going to look a little bit different when you do the demonstration because we just ordered some more that are more, they're easier to use. They're coming in later today and I have to film this now. So this is your extension tubing set. You're going to hook it up to the hub, that blue piece on the needle. and then you're going to have a little bit of extra work. And then this is a access port that's needleless, and it also applies some backwards pressure. So when you remove a syringe, your solution shouldn't go bursting out of the tubing or anything like that due to pressure changes. These are what you're going to see in the workplace. They're really, really good. They also do have a clamp so that you can stop flow if you need to, which you should be doing when you're done. And the set that they're in is technically sterile. So this isn't sterile right now because I just touched it all over and I put it back in the case. But when we're in this container here at the start and I haven't opened it before, when I open it, all the contents inside, including the inside of the case, are sterile. The last things that I'm going to need are chucks, which I don't have in front of me right now. So we're going to want to chuck under the arm because this can be very messy. And we're also going to want clean gloves. Remember, this is a sterile procedure, but if we're doing it correctly, our hands should never be in contact with the critical areas of where we're trying to keep things sterile. After washing your hands and then organizing your equipment how you would like on the table, the first thing you're going to do after that is you're going to set up your extension tubing. And we do this in this order specifically because it's incredibly important that we don't forget to do it. If we get this all set up, when we get the IV catheter in and it starts to bleed because we have a good site, and we don't have our tubing set up, it's going to be really hard to hold the catheter hub where it should be, and then also get your tubing set up without someone else helping you, and you won't always have someone else in a room with you when you're putting it in IV. So we want to make sure that we actually set that up now. So what I'm going to do is I'm going to start by taking my packaging. We're going to pretend it's not open. I had to open it because this is different tubing than what you have, and it didn't have this hub on, and I had to put it on so that we don't add an extra step you don't have to do when the test comes. But we're going to take it and pretend I haven't opened it, and I'm going to set it up over here. I'm going to take it, I'm going to kind of peel it this way so that it's not contaminating myself or the device when I open it, and then I'm going to turn it around this way. As long as the paper doesn't fold back on itself, you don't have to worry about taking it off completely. Just make sure that if you're doing it, that you're not reaching over the stuff while you're doing it. It's important that we don't cross over the site like I did with my hand just there to demonstrate. Like, don't do anything like this when you're peeling because you're going to be reaching over your site, and then this isn't sterile. All right, so I have to get this catheter out. And then I have to prime it without breaking sterile technique. And you might say, Sam, how the heck are you going to, your hands aren't sterile, you're not wearing sterile gloves. How are you going to interact with that stuff without contaminating it? And the answer is I can't. At some point I do have to contaminate it, but I can control what I contaminate. So what I'm going to do is I'm going to be mindful of where I grab this IV so that I don't touch something that can't be contaminated. In this case, it's going to be the ends of the catheter. That's what's important. I'm also not going to try to touch the base of the container because if I touch that, I can't use it as a sterile container to hold the contents of the contents of the tubing once I'm done priming it. And remember, the whole point of priming the tubing is to actually just put some fluid inside of it so that when we hook it up to the patient and we inject our first medication, we don't inject a whole tubing's worth of air into their arm, because that could cause an embolism and kill the patient. So we don't want to do that. So what I'm going to do is I'm going to reach in and I'm going to grab the tubing right here. Really, it doesn't matter exactly where it is as long as you're not touching like up here, or you're not contaminating the end of the thing here. We're going to be removing this cap in a second, so we can touch that. So once again, so to clarify, I grabbed it from the container from here. So the only thing I've really grabbed is this little bit here. I'm going to take my syringe and I'm going to remove the cap without letting any of those components touch anything I don't want it to. And then I'm going to connect end to end without contaminating the cap to this part of the hub, the medication side of the tubing. Then what I'm going to do is I'm going to take this part of the catheter here. I'm going to remove the cap, and now that is sterile on the inside, this patient side of the hub, and I want it to stay that way. I don't want to contaminate it and then hook it up to the IV hub, because then I will potentially give my patient an infection from the microorganisms. And what I'm going to do is I'm going to bring this over and I'm going to put it back into the basin. making sure that, because before I didn't, I obviously contaminated a little bit of the base in here with what I did, but that's okay. I wanted to make sure that the end is not, the end where the patient side of the hub is not touching a contaminated part. But before you do that, I just want to kind of show you the dropping technique here. And I have a trash can. What I'm going to do is I'm going to prime the fluid by pushing some of it through the syringe until there's no bubbles. It's going to be off camera because I can't get the camera to do that in shot. But now I have effectively, I just flushed a little bit of the saline through the tubing. It's like a cc or two to get it all the way through. And now this tubing is full of saline instead of just air. You can see a little drop of it forming on the tip of the thing. That's fine. I'm going to take this and then I'm going to drop the tip into the container there. And now that's good to go. The tubing is primed. When I need this later, I can reach in, I can grab the tubing, I can connect it to the hub, and I'll be good to go. I'm also going to set up the rest of my IV start kit supplies. So I'm going to peel this back. Once again, this is all sterile. What's important is that I don't contaminate the sticky side of the tegaderm because that's the side that's going to be connected to the hub. Nothing else is going to be making direct contact with the patient's sterile site other than the cleaning swabs, which are in their own container right now, so that's fine. So I've got the betadine swab, which I'm pretending is this one for now, or a chlorhexidine, whichever. Both are usually acceptable for prepping skin, but I'm going to use an alcohol wipe for the demonstration because of the mannequin's skin. It doesn't work that great otherwise. So I'm going to put this here, and then I have my tourniquet here, which is rolled up in a nice little ball. So now that we've got our tubing primed, what we're going to do is we're actually going to be actively looking for an IV site, a vein that would be good for puncturing. And we're going to do that through the use of our tourniquet. So it's important while you're doing this that you don't contaminate this, like don't put your hand over it like I'm doing right now. And so if you have to kind of step around it or whatever, that's fine. But what we're going to do is we're going to take the tourniquet, and like I said, we're going to kind of cause a traffic jam with the venous return so that the blood does continue to come this way from the heart, but when it comes back, it gets stopped wherever the tourniquet is, whether it's here or whatnot. Usually you want this a couple inches above where you're actually going to insert the IV, because if you put it like way high and then you go down here, it's just going to take a while for the traffic jam to build up in the hand. So if I put this here, I'm realistically looking for somewhere here. So what we're going to do is we're going to put it on, and you do that by getting a kind of tight grip on one side or the other, looping it down and under like this, and then setting it straight. And realistically, this isn't going to be that tight if you do it like this. That's okay. A lot of people assume it's sort of a misunderstanding that you need to get this like unbelievably tight because that's how you get you'll get the best bulbous veins from doing that. While that does in fact work, ideally you don't actually want it super tight because you could restrict all flow of blood, which could be a problem, especially if you have tourniquet on for a long time. I know I'm talking right now, which adds time, but you also don't want to have the tourniquet on for very long. And that's just because it starts to feel uncomfortable for the patient. So you let Martha know before you put it on that, hey, I'm going to put this tourniquet on. It's going to feel tight, and I'll take it off and give you a break before we actually do the insertion. But right now, I'm just really looking to make sure that I am indeed going to have a good vein to go for. You might not see a huge noticeable difference in how the veins change when you put the tourniquet on here, but in the real world, you will definitely notice when you have the tourniquet on and when you don't have it on. The veins will get a lot bigger. You'll be able to see a lot more of what you're doing. Some other techniques that you're going to be using or verbalizing while you're doing this are by using strokes distal to proximal towards the tourniquet on veins. You can kind of see if you can move some of the blood flow up towards the tourniquet, which will then help promote that traffic jam and give you some sites to go for. You could also have Martha squeeze her fist, just kind of like when you're giving blood. That will help, and it'll help out by basically promoting circulation to that site. Your hand will say, oh, like I need more oxygen reserves here, so you deliver more blood. And then it also squeezes your veins, the muscle manipulation kind of in your legs, so that it kind of brings things back up. And once again, it gets up to here and it stops, and it slowly builds up, traffic jam until you get to where you actually are trying to go. You're going to look around at this time for veins. Just as a fun fact, some of these veins look really good, but not every vein on this mannequin has blood in it. This is all done through a blood bag that runs in and simulates by filling up these little tubes in the arm. My advice to you is to go for a site that has been poked many, many times already. There's one right here in particular that might look a little bit darker in the video. You probably can't see it very well from here, but it has been poked many, many, many times, which is what I'm going to use for the demonstration. Just because there were several times where I tried to do pokes on the underarm, which there are some on the underarm, but I was hitting veins that just don't have any blood in them, so nothing was coming back, and you should be expecting to see flashback during this test. So that's how you choose your site. Once you've identified the site that you're going to go for, you're then going to remove the tourniquet, and you can just do that by pulling on that tab, or really anywhere. If you just lift it up and go, that should be fine. And then because I'm going to be going here, then I'm going to actually start cleansing the skin and preparing from there. At this point, I'm going to put on clean gloves. You could have put clean gloves on when you first did the tourniquet session, but a lot of times when you're assessing for a site, you need to do some feeling of the veins. A lot of times you won't necessarily see something good, but as you palpate the arm, you'll start to feel some soft, sort of almost like rubber hosey, spongy type stuff going on the arm, and a lot of times that's going to be your good sites right there. Because I could see so well, I just sort of ID'd a spot and then felt it a little bit with my fingers. People tend to have a little bit better job palpating and really getting the feel of a vein if they don't wear gloves. It's your call though. If you want to wear gloves, maybe the patient has a lot of lesions on their arm, or they're like really sweaty because of their they're febrile or something like that, and you don't want to get that on your hands. Totally fine, no worries at all. Otherwise, if you just want to put them on once you get to this part of the test, that's fine too. So what I'm going to do first here is I'm going to cleanse the site, and I'm going to do that with an alcohol wipe. As I said before, in real life this is actually going to be a chlorhexidine or an iodine prep pad. However, we are not going to use those on Martha's mannequin arm today. These are not ideal for that. So I'm going to take the wipe, and I have identified my site. It is still right here, and I am going to take the site and I'm going to do some very serious wiping on here for a considerable amount of time. I believe that it's like 15 seconds or something like that. And I'm going to really get on this this vein and do some good scrubbing here in a circle. And I'm doing that because part of what makes chlorhexidine and iodine effective is that they need to, first of all, have a good scrub involved, and second, they need to fully dry. So those are the two parts: the mechanical debridement from the scrubbing itself and then the drying afterward. So once I get most of that set, I'm going to do concentric circles around it to not go over the site again with these wider arcs, and that's just going to give my hands more space to work with so that I don't have a problem. So I've really cleaned off this area, but now I have to let it dry. If I scrub it off and I let it be wet and then I insert, I haven't necessarily killed the microorganisms yet. And you're going to find lots of people in the workforce don't let their they don't let the arm completely dry. And in our test, we even give you a good thing to do while you're waiting for it to dry, because it takes about 2 minutes. For me, it's just going to be explaining to you what to do. But while it's drying, you should be talking to your patient about what to look for if the IV site gets infected or if it's infiltrated, what they would be experiencing, and then also to let you know if those things happen. So like when you insert and then you test later, if they're feeling sudden pain, the site swells up around the vein, that kind of a thing while you're flushing, you're probably infiltrated, and your patient should be able to identify what some of those things are. So just keep that in mind. While you can explain that to them, and then by the time you're done, most likely this will be completely dry. At this point, I'm going to reapply the tourniquet, and then I will get ready for the insertion with the catheter. Okay, just wanted to bring up something. Earlier, per the sheet, while you're setting up the tubing, you should also peel a couple pieces of tape for yourself and just set them on the edge here. It's okay if you forget to do that until the IV insertion itself, like I did just now, because that's not going to affect, it's not going to cause a problem because you didn't get it done earlier or later. There are several things that need to be done before you actively stick the patient, and this is one of those things, but you won't be docked if you do it a little bit out of order there, no worries at all. So remember, my site is now cleansed off with chlorhexidine or chlorhexidine, as it were, and I have my sterile tubing set up over here. I've got my tape. I know my dressings here. I just took the time off camera to write my initials, date, and time on this sticker. There's really no particular, like, you don't have to write it a certain way. Don't worry. As long as you have the information on there and it's clearly identifiable, or you use a piece of tape and do the same thing, you'll be fine. So what I'm going to do now is I'm going to apply my tourniquet. And when I do that, it's important that I make sure not to contaminate both the IV tubing and the site that I just cleansed off. So this is the part when I reapply the tourniquet, and I'm not going to be doing any of those distal, proximal to distal techniques or anything to make the veins bigger at this time. You might have Martha squeeze your fist a little bit, but the idea here is that if I touch that site again, I'm going to contaminate it. So I'm going to put the tourniquet on, and now I'm going to say, Martha, you're feeling a tightness from the tourniquet. I'm going to be using my stylet in a minute here, which is another funny way of saying a needle. And that needle is going to poke your arm. It's possible that it might hurt a little bit beyond just a little sting. What's really important is that you try not to move this arm as best as you can. If you move the arm, it could affect where my stylet ends up going, which could make things hurt even more, or it could make me miss my target. And if I miss the target, I have to try again with a new needle. So we really want to make the most out of each attempt that we have here. So if you can try to stay still, that would be absolutely fantastic. So the tourniquet's on. I can see my site is already starting to build up a little bit. And now I've got my my angio catheter here. I'm going to open it up. Remember, there's a button on here. I'm trying not to hit that until I'm actually ready to retract the needle. Otherwise, I just have to throw this in the sharps container, and it's a complete waste of an angio catheter. I'm going to remove this hub catheter, or the cap, not the hub. And then when I'm doing this, I need to make sure that I loosen the hub off the needle. I don't want to completely take it off like I did earlier when I was showing you the parts, but I want to loosen it because sometimes it's on kind of tight at first, and if your needle is in and you don't loosen it first, it can be kind of a hard jerking motion to get it detached, and if you do that in the arm, you could ruin your IV site access, which is a problem. And you also make sure when you're doing this that you want to go bevel side up, which you probably can't see on the video, but it's that dark end on the tip of my needle. You can barely make it out. That's the bevel, it's the hole. You want to make sure that's up in the air when you do this, which should be in line with the button on the angio catheter. So once I have that set, I'm going to loosen my hub as I did before, and then I'm going to take my thumb on my non-dominant hand, because I'm going to be using my dominant hand to do this, and I'm going to anchor the vein. And we do that by going like maybe 5 or so centimeters distal to where we're trying to go in the arm, and that's going to help keep the vein from rolling on you or moving. If you remember, some veins are a lot harder than others, so as I advance this, instead of poking through, the vein might feel, the needle will take the path of least resistance. So it might make more sense if the vein just rolls out of the way, which happens all the time. But if you anchor it, it's less likely to do that on you, and you're more likely to actually get through the site. So what I'm going to do now is I'm going to insert the catheter and say, all right, this is the part where you're going to feel something, Martha, and I'm really sorry if it hurts a little bit. Try to stay very still. And you want to make sure you're going in at about anywhere from 15 to 30 degrees. So you probably don't want to go any more than this. And that's just because if you go completely flush, you won't necessarily get to where you're trying to go to. And you're going to poke the arm here. And you're going to wait till you get a flash, and if you can see it on my thing, that's the blood that just went into the catheter. You're then going to lower the catheter so it's flush with the skin. You're going to advance another millimeter or so, and then you're going to slowly slide that hub into the IV site. Once it's there, you're going to anchor it with your index finger and then apply some pressure to the vein distally up here. And then you're going to retract the needle. You're then going to take your tubing and you're going to attach it. Once I've got this anchored and stabilized with my index finger and I've stopped the flow here, I'm just going to remove that tourniquet, and then I'm going to check for blood flow. It's already kind of filled up the IV a little bit as it is, but as you can see, I'm getting blood return. I'm in the IV, which is good. and then I'm going to be flushing about 3 cc's, and I'm going to see if I can feel it moving through the vein, and then also making sure that I'm not getting any swelling in the distal sites here, that that Martha's not feeling any extreme pain. I just want to make sure that this is indeed working as it is intended. So I'm going to continue to flush to try to get that blood out. I'm going to clamp it just so that I don't keep getting backflow, because that's what's happening right now with this system. Now that the tourniquet's off, I'm going to take my Tegaderm. I'm going to peel this open, and I've got a system here where what I'm going to do is I'm going to take Tegaderm, I'm going to peel it open here, try to get that from not sticking to my hand, because it's all staticky, and I'm going to apply it just before we get to the hub. And when you do this, you want to make sure that you get it tight around the catheter site. That's really important, because if you get it too tight around the sides first, and then you work your way around it, you're going to have a raised section of Tegaderm where the hub lies right here, and then microorganisms can just get right in there, no worries at all. So I'm going to do this. I'm going to peel off the sides, and I'm going to take my labeled sticker that has all the information on it, and I'm going to apply it to the side over here. If I made a really big mess prior, I could take the 2x2 and I could really wipe things up down here, and I might still try to do that underneath the hub initially right here, but this is really just in case you have a really big bleeder. If you apply enough pressure with your middle finger here at the start, you shouldn't actually get a whole lot of blood drop. At this point, if I needed to, I could take a fresh saline syringe, which I've got one over here. If I did a better job of clamping this beforehand, I wouldn't have to worry about this, but I did not. But what I would want to do is I'd want to take a fresh saline syringe. Once again, this has not been contaminated by anything. This is a sterile end I'm hooking up here. Otherwise, I would use alcohol. I'm going to unclamp this, and then I'm going to flush it again. And that's just so that I can get this IV line as nice and clear as I can, and then I'm going to clamp the line. And the reason why we're doing that is because we don't want blood to sit in here if we can help it. Ideally, what happens is if it's clear and no blood, it won't clot in there and then form occlusions. And if it forms occlusions, then you have to do things like potentially change out the tubing, or even swap out the hub, which can be very problematic for your patient. Anyway, this is what you do there, and then in that case I'm done. Ideally, I would try to get a little more cleaned up, but I'm trying to talk to you guys while I'm flushing, and it's causing problems for me. That's good. Now what I need to do is I need to secure the line. I need to make sure that it's not going anywhere and we don't have any problems. So typically what we do is we set this up so that the catheter is leaning forward or leaning back towards the patient like so, and then we take two pieces of tape or one piece of tape and anchor it appropriately. What some people do is they take one piece of tape and they put a piece like this and they go across both. That's fine. It tends to be a little messier when you do it that way, so I'm not a fan of that. What I like to do is I like to take a piece and actually pinch it just below the catheter and then apply it to the skin, so that you've got a nice a raised section, which just tends to help give the IV catheter a little more flexibility, and overall just that tends to be very helpful. Because if you have some flexibility that way, if you have a really rough motion or something, where maybe the patient's like moving quickly, you have some give before, and the alternative would be that the hub just kind of gets ripped out of the skin. So that's what I like to do. It's actually what the people who make this tape for IVs, and like Tegaderm, that's actually their recommendation, is that you take the tape, you pinch it down a little bit on the sides, preferably a little bit more evenly than I'm doing it right now. Oh boy. All right, yeah. Pinch it on the sides, and then you can apply it like so, just on the side somewhere here. Things you don't want to do with this tape. You don't want to put the tape over the dressing, because if it peels off, it could rip up your Tegaderm, and then you don't have that good seal that you're trying to get around the hub here. If you do it like this, that should be just fine. And now I've got this access that's got a little bit of give on it. You can still access your clamp, no worries there. And then when we hook up tubing later, we'll probably want to take another piece of tape and secure that secondary line up along the arm. When you're done inserting your IV and you've explained to Martha, okay, we're all done, the IV's in and it's great, you're going to want to dispose of your equipment. You're going to want to take this this needle that you had, the angiocatheter and stylet, and you're going to want to put it in the sharps container. You're going to want to take anything that has lots and lots of blood on it, which shouldn't really be anything, but just in case you do have a large amount of blood, that should go into biohazard waste. I would consider putting these two things in there. So I'm going to take these and put them in a biohazard waste container. Anything else that's like, you know, wrappers, or if you have like a couple pieces of pre-peeled tape or something like that, you can throw those away. Typically we throw away, we don't reuse tourniquets, so that'll get tossed too. If you want to save the tourniquets for us, that would be awesome. What you're going to want to be saving for the for your practicing is, ideally I'd want you to be trying to reuse this tubing, and then also keep the wrapper that you're using for that tubing so that you can practice having a sterile basin to work in. We're not going to be throwing away the saline syringes. What we're going to do is we're going to have a cup over by the sink in the lab, or a pitcher, and we're going to have you just put them into that cup, and then we will be refilling those with distilled water. It's important that you guys don't refill them with tap water, because if you put tap water into these arms, they stop working. So it has to specifically be distilled water. It's a very high maintenance, fancy arm, so we're going to try to accommodate for that. The other things like the tape, the wrappers here, if you want to save your iodine wrapper to remind you that that's what you're actually going to be using, that's fine. Otherwise, you'll just be restocking we want you to be restocking your IV practice kits with some spare Tegaderm that we have on the table, like on your demo tables, and then alcohol pads, and then put your tourniquet and your tape back in, or use new tape, whatever you want to do for that. Otherwise, just once again, make sure that your angiocasts, when they're used, they go in the sharps container. If you have a spare one, by all means, just put it back where the other ones were. And then for the chuck underneath the arm, if you got a significant amount of blood or anything on it, please swap it out. You can throw the old one away, but otherwise just keep it where it's at, and that should be just fine. Okay, gang, sorry that there's a bag of fluid right in your face right away, but I wanted to let you know that some time has passed since you inserted the IV in your test, and now we have primary fluids running through, which you'll want to confirm that we have indeed normal saline that is not expired, which you can check for the expiration date on there. And hanging it up on the IV pole. And then I've got the settings set here, which we can see that we are indeed running at 50 milliliters per hour, as the order is, or 50 cc's per hour, whatever the case is. You can see this blinking indicator. This is a Plum Metrics pump, by the way, Plum A Plus system. You're probably not going to see these in practice a whole lot. A lot of the companies around here use Alaris, which we do have one, and I will show you how that gets used in class. We have a lot of Plum systems here, so we're going to test you off on Plums. There are a couple areas around here that still do use them, and there's always a chance that they can make a comeback. I don't think that'll be the case, but we want you to be prepared to handle any technology that you might run into, depending on where you work, and especially if you work in places that don't have the latest and greatest, you might still have something like this. So this is the Plummetrics system. It uses it does use a cassette system for the IV. I'm going to stop this for a second and show you. If you pull up on this lever, you can release the cassette. And this is the cassette system. It has a couple of chambers where you can look for air, and then it's got a valve release here where that's the clamp. If you pull it out, the fluid will run freely by gravity, and if you don't, it'll be controlled by the drip. It slides into the cartridge like so. Then you pull down the lever. The tubing on these tend to kink right here, so if you raise it up and over your container, you should be, or your pump, you're less likely to get a kink, which will be a proximal alert. So I'm not going to clear settings, because I just resetted the cassette by doing so. And when you close the cassette again, it always does a check. It makes sure that there's no air in the cassette that needs to be taken out. You can take it out a couple different ways. For these systems, the easiest way to remove air from them is to just open it up and then let all the fluid drain through it. Flip the cassette upside down for a period of time so that parts of it fill up with the solution, and then you should be good to go. Point is that this will be set up for you for your test, just because I don't think it's hypercritical that you learn how to do that just yet, and we want to make sure you understand the components of secondary medications. So
You're going to walk in on the scene again as it is right now, where you have the supposedly appropriate fluids running on the top of the pump, and they're set to the correct settings in here. You're going to be taking your secondary medication, which you'll have reviewed when you go into the back room and or your med room to look up your medications. While you're doing that, your evaluator will set up the pump. You're going to need a couple different things for this part of the test. You're going to need your secondary medication, to which you have performed 2 rights in the med room already, and you're going to perform your 3rd right now while you're talking to Martha about the medication and verifying that she understands what's going on with it. You're going to need some alcohol wipes, and that's important because we want to make sure that we are cleaning off these sites. We don't know how long this has been sitting here exposed, and so we want to make sure when we attach new tubing to it that we don't have a significant problem with that. And then we're also going to need some secondary tubing. And that's the kind of tubing that you'll know it's secondary because it's shorter, and it will come with a little holder that lowers the primary bag of fluids, which we'll get to in just a second. So once you make sure that you have all those things and you've checked that you have the infusion running at the proper rate, we can get started on the rest of the administration. All right, so I've got the tube set up. It's running for the primary tube setup. It's running the primary fluids appropriately. Now I'm going to set up that secondary system. I'm going to, first of all, it's going to be off camera here, but I'm taking a small piece of tape, which I forgot to mention in the supplies, and I'm going to write my initials and then date and time on it because I want to make sure that we are indeed identifying date and time on tubing. We would want to make sure that the date and time was on the primary tubing because we need to know roughly how long it's been set up for. So you would check for something like this. There was not one on here prior, but I'm going to pretend that it was there the whole time. You're going to look for a piece of tape like this that indicates, I have my date and time when it was started, because there are rules about how long you can keep tubing on. If it's continuous, a lot of places will allow up to 48 hours or 72 hours of time using the same tubing, even if you have to change out the bags. If it is a solution that is starting and stopping, you typically only have about 45 or 24 hours, sorry, 24, not 45, 24 hours of where you can allow that tubing to be reused, and then it has to change. Just be mindful, you shouldn't use the same tubing on different types of piggyback medications because there's the concern that they might not actually be compatible with each other, and there will still be some residue of that medication in the tubing. If we're giving scheduled antibiotics every 8 hours, we can use the same secondary tubing roughly 3 times before we need to replace it. So I've got my secondary here, and I'm going to take my tubing. And the first thing I'm going to do is I'm going to open up the package. Usually there's a perforating line that you can just pull apart. It really depends on the tubing though. Sometimes you really do just have to rip it open. And as I mentioned before, there are a couple parts to this tubing. I've got the actual tubing itself, which is usually a rather short piece of tubing. It's going to have a simple clamp to regulate by gravity. What I'm going to do is right now is I'm just going to close that clamp so that as I spike the fluids, I don't instantly just have a gravity pour of fluid run through the tubing, and because I don't want to lose any of my antibiotic to the floor. It's important that the patient gets all of the antibiotic. And then I have a capped spiked end. That's going to be important for when I insert the solution into the bag. And then I also have this nice little clip here that I can hang on the pole and then use that to lower my primary bag. Not every IV pump system actually uses gravity to facilitate the flow of the fluid. Some of them use different systems. However, if you have tubing wide into a primary site and it does use gravity, you need to lower this primary bag below the secondary bag so that it pulls from the secondary bag first, and as that bag runs out, then it moves to the secondary bag. And that's important because we want to make sure they actually get the antibiotics. If they were at the same height and I hung this up, I could be thinking that they're getting their antibiotics, and I could come back 2 hours later and find out that this never actually emptied out, which could be really bad for the patient. So what I'm going to do is I'm going to take this primary bag, and I'm just sort of going to start by using one hook side here and putting it on like so. Another thing that you can do, if you don't need quite that much difference in height, is you can take both ends, loop it through, and then just bring it about half height instead. Depends on how big your secondary bag is. Sometimes it's almost as big as a liter bag, so then you want to actually have that extra distance. But ultimately, if this is a little more convenient for you and the bag's not going to be a problem in terms of height, you're fine.
Now what I'm going to do is I'm going to spike this bag. Now these bags are reused and refilled, which is not something you're going to see in real life practice. So the biggest difference will be when you pull the tab, the rubber tab off of the bag that you're going to use in real life. If you have it hanging upside down, because the seal hasn't been broken on the inside, if you pull this off, you won't have waterfall come out of the bag. It shouldn't drip out. These will, which I already had to do one retake on this because of that. So what you're going to want to do is you're not, in real life, you could probably just pull the tab while it's hanging up here and spike the bag without any problems. But for the sake of practicing, which and this is totally fine for normal bags too, you can do it this way, which is why I'm telling you to do it this way now, is you are going to want to have it upside down when you pull the tab so that the fluid doesn't come out. Not a problem in real life, but will be a problem in this test if you do it that way. So what you're going to want to do is you're going to want to use both of your hands and wear clean gloves. You're going to take the spike cap and you're going to throw it away, or in this case you're going to save it just for the sake of the test. We're going to take this rubber tab, we're going to pull that off. And as you can see, a little bit of fluid just drizzled out. That shouldn't happen in real life because the seal won't actually be broken yet. It won't be broken until you do this, where you insert the spike the spike into the bag, and that's where you're going to pierce through the rubber barrier, and now this would be a free-flowing bag, which is why it's important that you clamp it, because otherwise the fluid without being clamped would just run through the tubing out of control in a way that you were not anticipating. So now that I've got it spiked and it's sufficiently in there, you don't have to get the entire thing up in there, and you'll know for sure because if you do a little squeeze like that, you should be able to get a little bit of fluid draining out of the container. You're going to take the bag, you're going to hang it up, then we're going to take our nifty alcohol pads and wipes. We're going to scrub off this port here. We're going to do a good 15-second scrub on the port, and that's just to make sure we get all of those microorganisms off of it without any worries. You know, we want to make sure that we are not introducing anything to the IV system, because this is once again going straight into a vein. A lot less security in the veins, much better effects for medications, but also very, very opportune environment for infections. So we're going to take that, we're going to throw the wipe away. I'm going to let it wait an appropriate amount of time to dry. We're going to pretend that that just happened because I'm impatient. I'm going to remove the hub from this tubing, which you're going to save, even though in real life you could probably just throw it away. I'm going to take it and I'm going to put this over the top, making sure not to contaminate anything. I'm going to twist it on to the tubing. I'm going to pause the pump and I'm going to lower the camera again so you can see what I'm going to be doing at this point. I'm going to take my clamp, which you can barely see here, and I'm going to open it up. I'm going to run the fluid, maybe I can just lift this up. I'm going to run it up like so and bring it down so you can see again. But now the clamp is open, and this is all connected to the cassette system here. And this is my secondary port like I wiped off. Now I'm going to do is I'm going to hit the back prime button. And this is a system that's going to pull fluid from the primary fluids down into the cassette and then back up into here to prime the line with saline. That's going to be very helpful because it will allow me to not have a bunch of air in the line, which will cause the pump to alarm mercilessly for the rest of your life if you're not careful. So I'm going to take this button, I'm going to hit the, sorry, I don't know if you can quite see that. It's right here. It says back prime. I'm going to hold this button and I'm going to watch the fluid run up the tube. You can see it's coming about, now it's kind of working its way into the back. And I'm going to let it run all the way up until it starts filling that chamber on the tubing, specifically till I get about maybe a third in at least. So now what I'm going to do is, it says according to this that on this left side, which is A, that was my primary setup. I'm going to be setting up something in the Piggyback, which is going to be my B side. So I'm going to take my B side here, and it's going to say Piggyback, and I can be more specific than that. Right now it's just saying whatever my secondary med is, that's my Piggyback. But I'm going to give it a specific drug so that someone can look it up later and make sure that I didn't screw up. So I'm going to hit therapy, and then I'm going to scroll down until I find my medication, which is cefazolin. So I'm going to be hitting the page down button, and yes, this is a little tedious, but luckily it's not too far off the med. Then I'm going to use these arrow keys here on the select button, or the select arrows, to go down to cefazolin, which is right right there. Sorry, I don't know if you can really see this all that well, and I apologize. And then on these tabs here, there's an enter. So I'm going to enter that, and then I'm going to be doing a dose calculation. I'm going to choose that, and I'm going to say milliliters per hour is what I'm going to choose on that. It's the first option. Then I'm going to use the arrow keys to go and then do what I need to do. I believe that this is going to be infused over 30 minutes. And I have to, it's a 50 cc bag per the MAR. So if I have 50 cc's of fluid that have to be administered over 30 minutes, I know that I could administer 50 over an hour by setting it to 50 milliliters an hour. I have to double that rate to get it done in half of the time. So what I'm going to do is I'm going to set it to 100. Once again, that's just a fluid rate calculation. And then I'm going to go down for, that's VTBI is volume to be infused. And I'm going to say, well, it's only a 50 cc bag. What I'm going to do is I'm going to set it to 55. At least on an Alaris pump, if you do that, it'll just run a little bit of saline faster than that, and then you shouldn't have a problem. And then what I'm going to do is I'm going to hit start. Attention, the line is stopped and delayed. Line B in piggyback mode gives no KVO or alarm at dose end. You're going to say yes. And then you're going to let her drip. And right now, this is, you want to watch. You want to watch your chamber here and make sure that you're seeing active dripping in the line there. If you see that happening, you know that it's actually pulling from the correct bag and you're doing the right thing. You're going to want to come back and check on the bag when it's close to being done, so that you can make sure that it either automatically goes back to primary, or that you reset it to its primary settings and restart the primary fluids. If you can do that, you should be good. All right, now that we're done with the IV pump administration, we've got the medication set up, we have that IV already in from before. Now we're going to talk about what we're going to do after the fact. So first and foremost, you're going to want to come back when that medication should be done, and then just make sure that the primary bag is now indeed running again, which is just, once again, this is something you're going to verbalize. You're not going to wait half an hour and then come back during the test to do that. But you're going to want to make sure that you know that you have to come back and make sure that the primary fluids are running at the appropriate rate and that they're actually running, and not, we don't have an alarm beeping or anything like that. With that, you also want to make sure that the IV is staying good throughout the continuous fluid administration. If that line infiltrates and we have continuous fluids running, they could be filling up the surrounding tissues instead of the vasculature, which, depending on what the fluids are, could be anything from a lot of discomfort to literally destroying her tissues and skin in the surrounding areas. Either way, Martha needs to know signs and symptoms to look for an infiltration, which you should know and you should verbalize off to us during the test. We're going to want to document everything that we did, that we inserted an IV and where it's located, if there are any issues when we did that, that Martha was educated on the importance of her IV, that she was educated on her medication and was knowledgeable a while before you administered it, that you really are taking all those target assessments that you did at the start, like the respiratory assessment, and you are documenting those as well, because if you don't document them, you didn't do them per records, and we need to make sure we're establishing good documented trends in her condition so that other people like doctors can review it and then see if they need to be doing anything to intervene. So lastly, just make sure that once again, that your medications are documented, and then you should be good to go. Once you've done all that and the other stuff that's not in this video at the start, you will be complete. We'll go through an evaluation on, we'll talk about how you did on the test, and then we'll get your grade. I wish you the best of luck with this. If you have any questions, please let me know. That's what I'm here for. I very much want you guys to do well on these, but I can't help you if you don't let me know. So please just come talk to me, and I'm more than happy to help you out.